Good evening, ladies and gentlemen. Welcome to the Royal Canine seminar, All You Need to Know About Canine Atopic Dermatitis. Atopic dermatitis is a very common yet complex dermatology syndrome, and in which nutrition plays a key role on the management. So for now, we will have the seminar section run by our guest speaker, Dr. Nellie. Dr. Nellie Choi completed her undergraduate veterinary degree at Murdoch University, Western Australia in 2009. After graduation, she worked in various general practices in Australia before starting a veterinary dermatology residency in California with the Animal Dermatology Group. Dr. Choi has worked as a registered veterinary dermatologist in Los Angeles, Perth, and various satellite clinics in Western Australia. And now, Dr. Choi is in the multi-specialty team at the VSH with the veterinary dermatology department. Her specific passions in dermatology are allergies and ear disease. Dr. Choi will present with us with the topic Canine Atopic Dermatitis in 16 minutes. In her lecture, she will start by the updated definition of CAD, the pathologist to the medication choices, as well as other parts of the multi-module treatment like immunotherapy. So now I hand it over to you, Dr. Nellie. Thank you very much.
Hi, thank you everyone for coming. It's a really hot day in Hong Kong, so I really appreciate you all coming out and making your way here. And thank you so much, Royal Canin, for sponsoring this event. So at the end of the night, make sure you thank our lovely hosts. But without further ado, I'm going to start because 60 minutes really is just not enough to talk about atopic dermatitis in dogs. I could probably go on for at least a week on this topic, so I'll try to make it nice and quick and clinically relevant for everybody, because I think that's usually the main pearls that everybody likes to take home. All right, so just a really quick intro, but like how I kind of mentioned, I did my residency in California with a really amazing dermatology group called Animal Dermatology Clinic. I was boarded in 2018 and since moved around a little bit, but we're pretty settled in Hong Kong now. So we've been in Hong Kong for almost 3 years in the multi-specialty practice VSH, and we're pretty happy where we are. No plans of moving. I think we moved 3 countries in 5 years, and we said that was definitely enough for a while. So but yeah, Hong Kong's been really, really, really great to us. So we're very happy and grateful for the opportunity working here. All right, so just a quick outline. I'm going to go through, I know most of you understand what atopic dermatitis is or the definition. I'm not really going to go into the nitty-gritty of the immunology and things because I do feel like that often puts everyone to sleep. So I'm going to touch on really how we diagnose canine atopic dermatitis and then move on to pharmaceuticals. That's probably one of the more interesting parts of the talk regarding what drugs we use and why, and for acute chronic flares. So we'll definitely touch upon those, and of course other multimodal therapies as well, because as we know with allergies, it's really not one drug that fixes all the dog's problems. It's a very, very long-term commitment, and often multiple things are required to keep a patient happy and stable. And again, allergen-specific immunotherapy is probably one of my passions within canine allergies. I really, really feel that it's something that is underutilized, and we really should try to introduce this earlier on in patients with allergies rather than them having 10 years of chronic lesions and kind of using immunotherapy as a last resort. And then of course there's going to be time for Q&A for everybody, including everyone in the room, and also I believe online as well. So feel free to type your questions in along the way, and we'll hopefully have time to go through all of them at the end of the evening. All right, so as we know, canine atopic dermatitis, a very simplified way of explaining is that it is a allergy after ruling out food and fleas. So it's a allergen-specific IgE process, and we don't think of it as a single disease, but actually a syndrome, because it encompasses many entities. And there's different clinical and molecular endotypes and phenotypes. And of course, with atopic dogs, I'm sure we've all seen in clinical practice, they all look different. Different breeds exhibit potentially different types of lesions, or more commonly certain lesions, and acute and chronic skin lesions also can happen at different body locations as well. So very typical acute skin lesions would be the erythema, the macules, and the patches that you see on a dog. This is actually a patient of mine, a sweet little Frenchie. And the first time it came into the practice, the owner was in tears. She'd been battling the dog's allergies for years, and she just feels like there's no end in sight. She gives all the medication, she bathes the dog, she keeps it away from outside, she doesn't let it touch the ground in Hong Kong. It goes around, everywhere in a trolley and a pram, and she just feels like it's still miserable. It still needs to wear clothing and e-collars, and it can't sleep well, and obviously that means the owner can't sleep well. So this is a pretty common presentation that I would see in Hong Kong, and often these dogs have been chronically affected for a long time. And most of these cases, it's not that they've been mismanaged. I think it just needs a very systematic step-by-step approach. Quite often, I find a lot of general practitioners do the very kind of reactive treatment. So, the dog's itchy, let's put it on an anti-itch treatment. But potentially maybe ignoring secondary infections that are actually causing the itchiness as well, not just the allergies. So we'll definitely talk a lot more about that when we talk about what an allergy march is in a patient's kind of allergy journey. So chronic skin lesions, often we would see plaques, lichenification, which kind of reminds me of rhinoceros or elephant skin, and hyperpigmentation. And remembering these are not specific to canine allergies, so a lot of different processes can also cause these visible signs, but it is something that I do see very commonly with dogs and allergies here, especially ones with secondary infection as well. So the common distribution, I'm sure you see this again in practice all the time, is affecting the dog's ears, around the mouth, eyes, ventral neck, axilla, groin region, kind of what you see in this picture here. Surprisingly, the dorsum of the dog is often spared, so you'll actually won't see a lot of lesions or pruritus affecting the back of the dog when they have atopic dermatitis. That's probably the only part usually that dogs look good, and everywhere else is a mess. Of course, with time, you can get secondary infections that spread onto the back, and then they start having lesions there and pruritus associated with that as well. So especially for young vets and vet students that might be here or listening, I highly recommend you to look up this article. It's an open access article that's been around for a while, and it's probably overdue for a review. It's written by the International Committee of Allergic Diseases of Animals. It used to be called the Atopic Task Force, and they review all the recent studies on treatments for dogs with allergies. So it's in multiple languages. It's open access, which means it's free to download. I really recommend every student that comes through shadowing our practice really have a read of this first before they come in, just so they have a basic understanding of what drugs are available and what might be suitable in what situations. So this is a classic slide of do as I say and not as I do. I used to use this pruritus visual analog scale a lot, or PVAS, and it was very helpful for me to blind owners to give me an understanding of how itchy they feel their dog is, rather than just an arbitrary scale of saying, okay, out of 10, how itchy do you think your dog is? And if you ask within a family, often they will give you completely different scores. So I do find giving the owner this scale without the numbers on the side, they circle where they think their dog sits, then I would obviously manage the itch, put them on treatment, and then at the recheck, ask them to circle it again. So you get a slightly more accurate score of how itchy the dog is at home. Because of course, as we know, in a 15-minute consult, you're not necessarily going to see the dog to be scratching and licking its paws like they would at home when the owners are staring at them for 12 hours a day. All right, so what is canine atopic light dermatitis? This I feel like I have to briefly touch upon. It's not your classic atopy in dogs. They do have the clinical signs of atopic dermatitis, but some people may know it as intrinsic atopic dermatitis. And these dogs have no detectable allergen-specific IgE, so which makes it quite difficult to consider even doing immunotherapy. And it's actually still very unclear whether this presentation actually represents the early stages of dogs with atopic dermatitis or whether it's a completely different subtype of the syndrome. So hopefully there aren't too many of these dogs running around, because unfortunately, besides symptomatic treatment, it could be very difficult to try to address the actual allergy or the atopic light symptoms. So skin barrier abnormalities should really be mentioned as well. And I think this is, again, one of those things we don't talk to owners about enough. There are a lot of current studies reported with decreased ceramides in dogs and alterations of filaggrin expression and higher expressions of enzymes involved in filaggrin metabolism. So this all usually causes things like gaps in the skin barrier. So there's going to be transepidermal water loss, so the skin is prone to drying. So atopic dogs, often they get scaly, you get dandruff, and as a result, sometimes they can actually be very itchy from the dry skin, as humans would as well. So repairing the skin is also important, not just addressing the itch. And of course, I will talk about at the end, when we go through the multimodal treatments of what I would recommend for these kind of defective skin barrier cases. All right, so this is what we talked about before regarding the allergy march. So allergy march to me is a slightly different in humans. I think in humans, we talk about the natural progression of allergic disease from infancy to adulthood. So these are little kids that have eczema, they might have asthma, and then as they get older, potentially that keeps progressing and gets worse year after year. As we know with dogs, they do follow that. And I always tell owners, because they always hope that the dogs are going to grow out of their allergy symptoms. Like, is it really true that, my vet said it needs medications for life? Is that real? And unfortunately, in dogs, it is in most cases. In people, not everybody goes through the allergy march. So you will have young kids that have eczema or asthma quite early on. And by the time maybe they're in their teens or even younger, they would actually be asymptomatic without significant medical intervention. But most of the cases we see with dogs, unfortunately, don't have this natural desensitization that humans potentially have. So often the very classic distribution or the classic symptom we would see is this non-lesional pruritus. So whenever I talk to students, I always ask them what they know the difference between lesional and non-lesional pruritus. So for me, non-lesional pruritus often indicates more likely to do with allergies. But if you have lesional pruritus, it's often a secondary infection that potentially is making them itchy. So it's important asking owners the question, do you notice your dog itching at nothing on the skin, or is it only itchy on the patches where there's crusting, papules, lichenification, or just visibly abnormal skin? With early onset allergy symptoms, it's often non-lesional pruritus. So the dogs are basically just scratching at their skin and the fur looks normal, the skin looks normal. Of course, with time, when they excoriate themselves, they can get secondary infections and it starts looking more abnormal. But the very, very beginning, it is often non-lesional. And then, of course, they progress to the bacterial pyodermas, the paronychias, the Malassezia dermatitis, and the paronychias. So that's a very common area I find also people miss, is just pushing that hair back on the claws and looking at the claw folds. Because quite often when dogs are licking their feet, it's not just from allergies from the ventral aspect or the interdigital areas, are actually licking at that infected kind of claw bed. And so just remember to sample that, take a little cotton swab or end of your Q-tip and just swash some on a glass slide and do a good cytology to look for the yeast or bacteria, because you do need to treat that as well. And then, of course, a lot of dogs also have secondary ear infections, which can progress to, unfortunately, otitis media. Then they get the head tilt and owners get very worried because it's quite often a very acute, sudden onset. All right, other allergic presentations we talked about just now. So with the otitis, I find this is a very common reason for referral, is often these refractory ear infection cases. And again, it doesn't mean that I have any special medicine that I use to treat otitis. I think it really is just a systematic approach. So the reason why I've circled this is because of the hair that you can see in the ear canal. Often the question's always, from owners and from vets as well, is to pluck or not to pluck. So are we supposed to remove this ear hair, or are we supposed to just leave it alone and not aggravate the ear? For me, if it's affecting your ear medicine, it should be removed. Of course, if the dog is in a lot of pain, I'm not going to hold a dog down to pluck the ear hair out. That's inhumane. But if it is in the way and unfortunately you can't clean the ear properly, or if the owner can't clean the ear properly because of the hair clumping, then it may be worthwhile to offer something like a sedation and actually give it a quick little ear pluck, clean with saline, and just get majority of that exudate out of the ear before sending the patient home on whatever ear drops you're going to send it home on. Often the ear drop you use, if you're not seeing results, it's not because of a resistant bacteria. It's actually very uncommon for me to see bacterial resistance with ear drops, because remember, you're drowning the bacteria with extreme concentrations of antibiotics. You're not using systemic antibiotics to treat an external ear infection. So most of the time, it's because it's complicating factors such as the hair clumping inside, there's a large wad of ceruminolith or something, or potentially if there's middle ear disease, of course, then that needs to be addressed with a general anesthetic and an ear flush. But otherwise, if it's not an infected ear, my general rule is don't fix it if it's not broken. So if owners are asking, should I be plucking the ear hair, but the dog's never had a single ear infection in its life, then I say don't touch it. I know that goes against what most groomers would recommend, but I feel like plucking it often aggravates it, and then you may actually create a secondary infection. So other classic allergic presentations would be the interdigital furunculosis. I feel I don't see as much of this in Hong Kong as I did in Australia. I think it's more likely due to the types of dogs we see, or the breed of dogs we see. There's a lot of short-coated English bulldogs in Australia, whereas in Hong Kong, English bulldogs are not really as favored or as popular, but both these patients are derm patients in Hong Kong, and you can see this huge furuncle in this English bulldog, and you just kind of want to burst it with a needle, but unfortunately it was very, very chronic, so it looks like it's filled with fluid, but majority of that is actually scar tissue. And then the paw on the right was a corgi paw that had all 4 of its feet bleeding. When it walked in, everything it touched on the ground was basically covered in blood. And so this poor dog barely could walk from the pain. So it can affect, it's not always just itching. I guess this is the point of the slide, is it can really sometimes affect the quality of life of dogs a lot more than just being itchy. With these cases, just remember secondary infection needs to be treated. I mean, you look at both of those, there's going to be bacteria in there, there's no doubt. And the best way to sample, especially that giant furuncle, is going to be using something like a 22 gauge needle and really trying to aspirate as much of the fluid as you can. Even if you don't get a huge amount, I would still kind of almost have as if you're FNAing a lump, and try to sample that onto a curette and send it off for culture. Because swabbing the top is obviously not going to get you anything. You need to really get the sample from underneath. So this is slightly more rare. This was a patient of mine, again, recently that developed urticaria. And of course, you can get angioedema as well. And I'm sure a lot of GPs would see angioedema potentially from vaccine reactions, so type 1 hypersensitivity. But this is kind of more to do with atopic dermatitis that I'm covering. So these are potentially, could be anything, could be food, it could be insect, it could be, anything in the environment the patient has had contact with. The best way to get rid of these are still steroids, unfortunately. There's really no new breakthrough with urticaria or angioedema that I know. And often it's really trying really hard to find the source. You can treat it with steroids and it goes away, but if it's still being triggered by the allergen, it's going to keep coming back. So for this particular patient, it seemed more to do with the food. So the owner was trying to convince herself that it wasn't the diet, but the moment we switched it back on the Royal Canin hypoallergenic, the symptoms were way more under control. So every time she introduced a new treat or a new kibble, and it would flare up again. So the difference, I guess, with urticaria as well, because quite often I find some vets or even owners would mistake urticaria on a short coat dog and folliculitis, because on physical presentation, they look identical before you touch the dog. The hairs are standing up in little clumps on the back of the dog. And so it's very difficult to differentiate between whether that's actually a type 1 hypersensitivity or whether you're dealing with a bacterial folliculitis that requires potentially antibiotics. So usually I tell owners, try to circle the spot where you see the hair standing up, or the other test you could do is gently tug on the hair. And if it comes out in a clump and you see kind of like casting at the end, it's more likely folliculitis. But if you're tugging and it's not particularly, moving, or the hair doesn't come off, it's not epilating, then it's more likely a urticarial problem. The only way to really see clearly, though, is you're going to have to shave the dog where the hairs are standing up, which most owners probably would not appreciate. But yeah, this is actually quite interesting because I do find some vets might mistake folliculitis for urticaria and vice versa. All right, so with dogs versus people, I find this to be a really interesting article by Marcella, and you can see the pictures of people's skin or people's with atopic dermatitis, and often they would have rhinitis and asthma, so different manifestations of atopic disease, which are very common in people. But for dogs, the most part does tend to be more cutaneous. So I'm sure you all agree, most of the itchy dogs you see from allergies very rarely seem to have signs of rhinitis or asthma or require inhalers and kind of sinus kind of medications. But in people, unfortunately, they seem to manifest all over from, respiratory wise as well. But I really like this picture because you can really, like at a glance, it's actually quite difficult to see the difference between human and dog skin if you're not looking at it clearly, because they're both very erythematous. They look super poritic. They've got papules, they've got thickening, dryness, scaling. I mean, really, it's the same. Dogs can develop these just like with people with eczema as well. All right, so that's us with talking about atopic dermatitis. So let's move on to the fun stuff. So pharmaceuticals, so we always know them as drugs. They're often in allergy cases. They are Band-Aid therapies. They require monitoring. We need to know about their adverse effects and talk to the owners about adverse effects. And different ranges of drugs often can be either expensive or cheap as chips. So we'll go through a couple of these. Just a little timeline of drugs throughout the ages in the derm world. So very, very early on, we had Atopica, which we know as cyclosporin, the calcineurin inhibitor, and this was the first immunomodulator specifically approved for treatment of canine atopic dermatitis. So I think a lot of you might be too young to use, Atopica before, say Apoquel and things were on the market. But after Atopica, then we got Cordyvance. Well, this isn't a systemic drug. This is a topical steroid. So this was made by Virbac, was the second pharmaceutical intervention approved for allergic skin disease in animals. And then in 2014, which is 10 years after Atopica, we finally had our first in-class Janus kinase inhibitor, oclacitinib, or as we all know as Apoquel. So this was created by Zoetis and available to treat atopic dermatitis in dogs, and actually human disease. They have a similar Janus kinase inhibitor approved for human disease as well. So finally in 2017, hooray, we had Cytopoint. It's the first monoclonal antibody fully approved for canine disease that specifically targets IL-31. And of course, now we know there's way more monoclonals that's actually recently released. There's ones for pain in dogs. There's Silencia and Librela and all of those that's on the market. But Cytopoint really was the groundbreaking monoclonal antibody that we had in the veterinary industry. So it was very, very exciting when it came on. And I'm sure most of you would have had experience with it or have it now in the clinic that you use regularly. But again, like the previous slide suggested, these are all what we call Band-Aid therapies. The moment you stop any of these meds, injections, the symptoms really are still there and persist, and they will relapse. So we categorize usually drugs as broad, semi-broad, and specific. So like we kind of mentioned before, the Cytopoint or the low-key vet mab is very, very specific because it really just targets one thing. And hence, that's why when I explain it to owners, why it's so safe and also why it's so expensive. So Cytopoint, in terms of safety profile, it's superior to any other things really that we have besides antihistamines. Antihistamines, as I'm sure also you guys have experience with allergies, it's a very poor antipyretic. If you have a severely itchy dog that's coming in, don't prescribe it antihistamines because you're not going to see a difference. It's really just, you won't even get see the placebo effect. The dog's still going to be continuously very itchy. It's really for very mild pruritic cases. And the semi-broad one with Apoquel, again, is gaining, very, very popular. We use it daily, I'm sure, with allergic itchy dogs. And the broad ones, of course, are the steroids, the cyclosporin, that probably are less in favor nowadays. It's not as trendy for managing itchy dogs. So let's talk about steroids first. This is the longest history of drugs. In Hong Kong, I tend to only have access to prednisolone, but there are various other steroids available in tablet form like triamcinolone, like in the States. Of course, there's dexamethasone as well and methylpred. I don't love Depomedrol injections. I know this is going to make me very unpopular to some, but I do find it's one of those very scary injections that I can never take back once I give it. And if you make a dog or a cat diabetic, whoever has to manage that case or the diabetes, I feel sorry for them because it's difficult. I mean, the body is just swimming with steroids and you're trying to get the hyperglycemia under control. So potentially for 1 to 2 months, that cat or dog's BG is going to be all over the place. So Depomedrol, I find, is for derm anyways. I can't comment obviously for other diseases that you might use it for, but for dermatology things, I really don't feel that it has a need for that to be on the shelf. So contraindications, I'm sure we all know, diabetes, cardiac disease, pregnancy, lactation. Obviously, don't use it with concurrent non-steroidals. There's a huge list of corticosteroid adverse effects. And I think most clients are well educated now to be kind of fearful of steroids, almost overly fearful. Sometimes, I would use steroids quite freely, particularly when it comes to ear disease. And they would often kind of look at me with kind of shock in their eyes. And I know that they've heard bad things about steroids and, they worry about side effects and affecting the patient's like longevity and things like that. But it's always for short courses. I would never recommend for allergies to prescribe steroids for weeks and weeks at a time. One of the fun things I always ask students to name me is list me at least 10 adverse effects of corticosteroids. Usually they get the PUPD and the polyphagia, but the skin things I find often is forgotten or missed. So skin fragility is definitely a possibility of an adverse effect. The symmetrical alopecia, they're more susceptible to pyodermas, infections in general, so UTIs even, and also calcinosis cutis. So that's definitely one that a lot of students forget to mention. And this patient, actually, I first saw, it's probably 2 years ago now, And this poor English bulldog had allergies and actually had been receiving monthly Depot-Medrol injections for 1 whole year. So it basically had 12 depot injections over the course of a year, which probably is the record for me. I've seen cats with monthly depot injections, but definitely not in dogs. So this was definitely the star of the day. And you can see all that gritty stuff that's extruding out of its back and around its face. All of this is calcinosis cutis. So this is a side effect of the steroids that it's been receiving. And of course, it was getting very itchy from the calcinosis cutis. And of course, then the treatment was reaching for more steroids. So it was kind of a vicious cycle of this itchy, treating just the symptom, and then making the skin actually visibly a lot worse. And just remember, out of all the dog breeds, I find English Bulldogs to be one of the breeds that are the most sensitive to steroids. I know people always say Great Danes are sensitive, but English Bulldogs definitely, they get calcinosis cutis with sometimes I feel like a whiff of steroid, and they'll just erupt these calcium salts through their skin. So I always think they look like a bit of an armadillo when they get that. So on histopath, if you're kind of nerdy and like to look at slides, this is what calcinosis looks like on histopathology. You get this deep purple calcium salts that are deposited along the collagen and elastin fibers in the dermis and the basement membrane zone. It's very hard to miss. This is probably one of those super easy exam questions if you ever do histo exams, and I don't think it would ever be placed as an exam question. It's probably too easy. You can see it from afar. You can look at it on the other side of the room and you'll see this dark purple stain calcium salts. And like we said before, often you get this gritty, yellowish white, almost chalky substance that extrudes out from the skin. And that's actually just calcium pushing through. And because you have all this foreign material, or not foreign, but this kind of inorganic type of mineral pushing through the skin, you're causing a lot of trauma. And most of these cases are infected with bacteria, no doubt. So there's significant trauma to the skin barrier and you'll get horrendous bacterial infections. So always remember the treatment to calcinosis, of course, is stopping the steroids and also treating the secondary infection. So one of the fun facts of calcinosis is dogs and chinchillas are the only known species of animals that can develop these from Cushing's or hyperadrenocorticism. So it's not just exogenous steroids, it's also endogenous steroids that can also cause calcinosis. All right, topical steroids such as Cortivans, there's so many different types of topical steroids, especially in Hong Kong. I definitely have noticed, and I'm guilty of this myself, us reaching for other non-veterinary approved topical steroids, like the human kind of eczema creams, and they all vary in strength and vehicle. So Cortivans is the licensed animal one, and it's in a spray. It does have this kind of alcohol carrier, so always I warn owners if there's broken skin or there's bleeding on the lesion, don't spray it on there because it's going to sting. It's very effective for localized lesions, but if you have a dog that's itchy from nose to tail, don't send it home on just Cortivans. And also, it's a pretty worth kind of your bang for your buck kind of product, because you do get up to 500 sprays per bottle. It's recommended not to exceed 2 sprays per 10 centimeters square on the dog once a day. I'm actually super conservative with topical steroids because I think I see a lot of cases where they're overused and then you get a lot of this kind of skin fragility, the cutaneous atrophy, and the secondary infection associated with overuse of steroids. So my kind of common rule is not to use topical steroids more than 3 times a week, especially when it's just for allergies. And this, doesn't apply for things like pemphigus or other autoimmune diseases. This is for allergy management. But I do love using topical steroids for localized lesions, especially if it can allow me to use less systemic drugs. I will definitely use topical steroids where I can. So other topical steroids that we have in Hong Kong are the Extracum, the Myacums, the whatever cums, and they're usually the triamcinolone base. And then also there's the betamethasone steroid cream, which are commonly, I think, found in Isoderm and Fusiderm as well. And when owners are applying cream, so this is different to Portavants, of course, you spray directly on the lesion. When they're applying the cream, make sure you just warn them to either wear gloves or to use a Q-tip for applicating on the dog's skin. Because remember, the owner's finger is normal skin. So if they repeatedly touch this steroid for every localized lesion that they use and using it 3 times a week, they're exposing their normal skin to excess amount of steroids, and that can cause atrophy and fragility on their own finger. So it's ideally not to use also when there's kids around or young babies crawling around, because you don't want babies to be in contact with excess amount of steroids that you just smeared on the dog. So this is a really really interesting picture that I have. You can see on the top, which is the initial consult of a dog that the owner had been using a lot of topical cream. And actually, I find half the time they don't even know it contains steroids. They're given like a tube of allergy medicine and they just go, oh, okay, and then they go home and start lathering on the dog where it's itchy and red, and then it seems to improve because the dog's less itchy, but then when you look at the skin, it looks like it's falling apart. So the picture between the top and the bottom is actually, I didn't do anything except to tell them to stop the steroid. So the skin is a super forgiving organ, so you can see that even just from looking like it's so scaly and atrophied and it's lost all this elasticity, it's all wrinkled. And then 4 weeks later, I mean, it's still hairless, but it's smooth, it's not red anymore, it's not dry, and this is really just with almost no treatment. I think I sent it home on some skin barrier repair oil or something, but definitely nothing, you know, super magical. All right, cyclosporin. So I'm not sure how many of you use this for allergies, but I do still feel there is a place for this drug for allergic dermatitis or management, and I'll go through some of the diseases that I use it for relating to derm. It's scary for some owners to hear about cyclosporin, especially if they're nurses or doctors. So when you bring up cyclosporin for the first time to a client that you might be trying to use it on their atopic dog, just especially if you know that they're in the medical field, just let them know that the doses we use are not the same as what humans use for like renal allograft. So these are cyclosporin in the medical world, often they associate it with renal transplant rejections. So when a human gets a new kidney, they load them up with cyclosporin so that their body doesn't kick the kidney out or reject it. So for them, it's a really strong immunosuppressive agent. And if they're hearing you using that on their dog for allergies, they're going to find it a little bit scary. So yeah, just explain the doses we use are approved for allergic dermatitis management, because as we know, Atopica is a licensed drug for that. So it also treats a variety of immune-mediated conditions. I use it quite a lot with things like pemphigus, but also being aware that Atopica, of course, is the one we're familiar with. There are also a lot of generics available. The main thing is that we need to make sure whatever generic you use, that it's an ultramicronized emulsion, because if you use the regular human one that's not in the ultramicronized emulsion, it actually has very poor absorption in dogs. So there are some cases when you're treating, say, like a 60-kilo dog and they require cyclosporin, but the owner just has no way of affording Atopica. You can consider using human cyclosporin, but just make sure it's not the oil-based type. Otherwise, it's not going to be effective at all. Also, remembering if the dog has other concurrent diseases, cyclosporin does have a lot of drug interactions as well. Obviously not limited to the antifungals and phenobarb, but definitely a lot longer list like trimethoprim sulfur and things like that. So make sure if you're prescribing this medication, just to get a full drug history of the patient before you do. All right, so Atopica, we know it comes in capsules and liquid. It's a calcineurin inhibitor, and like we said, it's kind of that broad spectrum medication. I use that at 5 mg per kg once a day for dogs. I like using it on an empty stomach where I can, just so that it improves the absorption. But otherwise, yeah, the most common side effect I find would be things like GI, vomiting and diarrhea. But often I find this is transient. So I usually tell owners if it vomits one time, don't worry. But if it repeatedly does it after a dose, then stop the medication and let me know. Of course, look out for diarrhea. Gingival overgrowth is one of those very weird things that you will occasionally come across with cyclosporin, especially when they have hyper absorbing abilities in the dog. And I have seen it in cats as well, but definitely more in dogs. It looks quite horrendous when you lift up the lip and you see this kind of like gums growing over the teeth. It isn't actually painful. The histopath of it is actually just the spaces between the cells. It's not actually hyperplastic. So hyperplastic by definition has increased cell numbers. There's not actually an increased number of cells in that gingival overgrowth. It's actually the spaces between it. So it's not particularly painful, except the downside is it can predispose dogs to dental disease if it continues to progress, because you're getting all these gaps between the gum and the teeth when the gums are just kind of growing down. So if that happens, adjust your Atopica dose or consider maybe using a different medication. But unfortunately, once the overgrowth is there, it doesn't retract back. So if it's bothering the owner, or if it is getting really bad dental disease already, you might have to kind of par down or shave down a bit of that gum under a GA while maybe you're doing a dental, and get it kind of straight again. I haven't had to do that many times. I think I had to do it on one lab a long time ago with a CO2 laser, but I don't see many of these. Well, I don't see many dogs with on Atopica now compared to before. So probably a lot less of this adverse effect as well. So one of the really weird things Atopica can cause also is hypertrichosis. And yes, that's not a typo, so it's not hypo. This is actually increased fur growth in really odd locations on a dog. And it's not a bad adverse effect, of course. I think most owners would very happily welcome this, but often it's in locations that you wouldn't expect. So I once had a dog that basically would only have hypertrichosis on Atopica between the digits. So it was kind of like walking like a bit of a Clydesdale, and it would kind of slip and slide a bit around. And the owner was always saying, oh, I have to always trim its hair around its feet because it's always tripping over itself. So that's a very interesting adverse effect of cyclosporin as well. So derm use with Atopica, I don't typically use it for allergic pruritus. So when you have a very itchy dog, I very rarely would give it Atopica for managing the itch, for a number of reasons. It's a very slow onset medication. So if you have a severely itchy dog, don't expect the itch to go away after 2 doses of Atopica. And also I find there potentially are other modes of therapies now that has a faster onset and better control of pruritus. But I do still love using Atopica for interdigital furunculosis and perianal fistulas. So perianal fistulas, again, the last one I treated was probably in Australia. It's probably a good thing. These things are horrible to treat. And also another good thing about it is perianal fistulas, as some of you may know, tends to only happen in German Shepherds. And that's definitely not a popular dog breed in Hong Kong, I find. And I'm very, very happy about that, because if you have an angry German Shepherd with a painful behind that you're trying to treat, it's never a good combination. But these are the 2 conditions in the dermatology world I find that I would reach for the Atopica. All right, so we talked about the generic cyclosporin. Here are some of the names. I don't know if they're super relevant to Hong Kong because I do rarely approve using generic cyclosporin for animals, but just remembering there are different types, and always pick the one that has a microemulsion and not the one that is in the oil base. All right, Apoquel. So very well-known drug, registered for dogs only, 3 different tablet sizes, and now they also have the chewables as well as the tablets. So also, make sure if you're doing a diet trial not to give the chewables of the Apoquel because they are flavored. It is a Janus kinase inhibitor, as we all know. So contraindications, I tend to tell owners, for me, there are 3 main rules with Apoquel. So anytime I start a dog on Apoquel for the first time, I let them know my 3 rules. One is they cannot be less than 1 year of age, so have to be above 1. And number 2 is no history of cancer or they're undergoing chemo. And number 3 is no presence of a deep infection. So this isn't a skin infection or a little UTI. I'm talking about like pneumonia. Of course, if they have pneumonia, they probably shouldn't come see a dermatologist, but these are just things that I warn them if they do get sick along the way while using Apoquel, make sure to stop the Apoquel if those things happen. And of course, pregnancy, lactation, all your regular drug contraindications as well. So a lot of owners do like to go on Google or Facebook dog groups and things, and I know there's a lot of circulation of things about Apoquel causing cancers and tumors in dogs. I don't believe that there is a strong correlation, and I'll explain why a little bit later. But do try to stick within the dose range with Apoquel. I do sometimes find when I see dogs already on Apoquel, they're on probably slightly higher doses that I'm comfortable with. Because remember, this is not a short-term drug. You're not going to expect to cure the dog's allergies with just 1 month's worth of Apoquel. This is a maintenance. It's a long-term medication. So just make sure the dose range is kind of within what the company recommends. So 0.4 to 0.6 mg per kg. All right, adverse effects of Apoquel. I'm sure most of you use it commonly and probably rarely see side effects. Well, that's in my case anyways. Very, very rarely I would see a dog vomit or have diarrhea with Apoquel. Again, polyphagia is noted, but again, not very common. Maybe 1 every 2 years I would come across a dog with polyphagia on Apoquel. Demodex is definitely one that you should be aware of, because if a dog does suddenly develop patches of hair loss and it's on Apoquel, definitely raise suspicion of scraping that hair loss patch, because you want to make sure that it actually hasn't developed demodicosis. When Apoquel was first on the market and I was a resident, there were a lot of talk about, when we were doing Apoquel blood work and urine monitoring, that they were picking up a lot of urine tests that came back positive for protein. So the proteinuria almost came up on every dog that was on Apoquel. And at that time, we didn't really know the significance. You know, they would go through, SDMAs and, all sorts of different testing to see if there was actually impairment of renal function, and really nothing was found. And I think in the end, they kind of decided it was more like a metabolite more than anything else, and it wasn't an indication of renal failure or renal disease. So I don't think there's any significance of that. So I've been really kind of maybe lax with making sure that I do a urine test for every dog on Apoquel compared to maybe, say, 6-7 years ago. I'm definitely just more interested in the blood work and the CBC and the biochem. Also, aggression has been noted in some dogs on Apoquel, which is a very weird side effect, because I find that more commonly with steroids more than anything else, but it has been reported. So that's another thing to just monitor for. So the reason why Apoquel, with what I was talking to you about, the neoplasia or the predisposition to cancers, is because of this paper. So this was published in JAMA 3 years ago now, and this was written by some of my mentors and also some of my resident mates. And basically they followed, it's a retrospective paper, and they followed over, I believe, 300 dogs in each group that were on, the first group on long-term Apoquel of more than 2 years, I believe, and then the other group not on Apoquel. And they were breed and age matched for each patient. So same, you're comparing hopefully apples and apples, not apples and oranges. And basically, statistically, there was no correlation between dogs on Apoquel for the 2 years to increase their risk of malignancy. So, I mean, 660 dogs is a pretty large cohort for a veterinary paper retrospectively. So it's enough data for most vets to be comfortable with dispensing this and not say, oh, this may cause cancer in your dogs. Because actually, if anything, my friend found there were more risk of the non-Apoquel group statistically than there was the Apoquel group, which is quite interesting. So if I have clients that are worried or vets that are worried, I usually would defer them to kind of check out this paper. All right, so Cytopoint, again, only for dogs, and I don't mean registered only for dogs, I mean only used in dogs. It is a caninized monoclonal antibody, so please do not inject it into a cat. So this is a very specific inhibitor of cytokine IL-31, and really at this point we have no contraindications, and hence the safety and hence the cost of the injection. I do use 2 mg per kg. I know some vets like using 1 mg mg per kg. I think starting from America and using it there, it was always 2 milligrams per kilogram for me. So I just never changed. And then somehow along the way, when I went to Australia, it was licensed for 1 milligram per kilo. But I feel like if we're going to try it, it's already an expensive injection. I just usually go big. So 2 mg per kg. And usually within, I would say, half a day, the owner should notice and decrease in itch. So yeah, the papers do say reduces clinical signs within 8 hours and provides 30 days of itch relief. And remembering to refrigerate the vials and give the whole vial to the patient. Don't split them up. And I also rarely send this home. I think I've sent it home less than 2 times in my entire derm career. And these were really exceptional cases where owners are living in very, very distant locations, or they're in the army and things like that, that they can't go in and out to the clinic. So, but again, very, very rare. All right, so there are studies to compare between Cytopoint atopica. Like I mentioned before, atopica seems to be slightly slow in onset. So you can see here on the far left, the vertical part is the itch score, and it is significantly lowered with the Cytopoint compared to the atopica. So hence, that's why atopica is really not a very good drug to use for a super itchy dog that you're trying to control the itch immediately. So reactive therapies are really the key to this is trying to induce remission. And this can be with steroids, it could be with Apoquel, but definitely not with antihistamines and atopica, like we said. And proactive therapy is more preventing the reoccurrence. So once you've controlled the itch, how do you stop this from relapsing? How do you keep the dog happy, symptom-free? And this may be long-term Apoquel, this may be topical steroids, but it's unlikely that they will be able to stop any of these therapies along the way unless the patient is heavily seasonal, which I find in Hong Kong, it's almost unheard of. Our seasons are all kind of jumbled together. It's hot and humid most months of the year, and it's really not cold enough where there's no allergens and all the trees and grasses all kind of wither away. All right, so antihistamine is the other super specific treatment. So we talk about the safety as well of these, but it just rarely works as a sole therapy. So remember, just don't bother dispensing this in a super itchy dog, but it does sometimes have what we call steroid sparing effect. So if I am using steroids for whatever reason for slightly longer term, then I would add on a second drug, which is the antihistamine, to hopefully be able to use less steroids at the same time. Contraindication of the antihistamine is super rare. So this is hypersensitivity. I think in my entire career, I had one dog that had a hypersensitivity to antihistamine, which is hilarious, I find, because it's like being allergic to something that kind of fixes you. But it was also a friend's dog, and I've never seen a hypersensitivity reaction in a dog with antihistamines before. So it was definitely not something I immediately recognized, but it was very, very clear. The dog was running around, whimpering, super hyper excitable, and just nothing was going to calm it down except, of course, steroids. So, which is what we ended up using. But unfortunately, this dog can no longer have any histamines. All right, so we have first generation and second generation. Second generation, I tend to use cetirizine a lot more. And the reason is it's less drowsy. It's very easy to dose, 1 mg per kg, once to twice a day. And again, like I said, generally very safe, inexpensive, cheap as chips, over the counter. You don't need prescriptions. Owners can go to a human pharmacy and buy a box of cetirizine very easily. You can use things like diphenhydramine and chlorpheniramine, which I know chlorpheniramine especially is a little bit more popular within the veterinary world. But I do find the drowsiness tends to be more obvious with those. But you know what? If an owner wants the patient to be a bit more drowsy because it's too excitable with his pruritus, then that might be a very welcoming side effect. So there are some papers talking about itch reduction and antihistamines, but again, I wouldn't use that as a monotherapy for itchy dog. All right, sorry, I think need to go a little bit faster. All right, so other treatments, we have essential fatty acids. Again, not suitable for monotherapy. They're not very good anti-itch drugs or supplements by themselves. I usually prescribe these for skin barrier function, making the coat and skin nice and shiny, but it can take up to 3 months or sometimes 2 to 3 months for actual any clinical improvement. And also, there are a lot of essential fatty acid-rich diets nowadays that I would probably prefer to prescribe rather than getting owners to give fish oil capsules, because I do find with fish oil capsules you can have GI side effects quite commonly. So at the dose in which I need, quite often dogs might have vomiting, diarrhea, and of course if they're prone to pancreatitis, this is a no-no. So if the patient has had pancreatitis before, hyperlipidemia, like if it's a miniature schnauzer or anything like that, I'd probably avoid using fish oils as a supplement. And of course, obesity. So if they're already a chubby round thing, so maybe don't prescribe the fish oils either. All right, so because we are sponsored by Royal Canin, I do have to do a dedicated slide. So this is a new diet that's coming up, which you probably saw at the front by the door, the Skin Topic. And this is actually some really good data. I was reading this paper while I was doing this PowerPoint, and there are really promising results of using diet to control or lower the itch score in dogs. And if it's something as simple as diet, instead of like upping the steroids or upping the or using multiple drugs to control the itch, I mean, why not? I think it's one of those treatments that we can all agree that is extremely safe. Of course, you know, as long as the dog eats it, then hopefully it works very well. So the dry food has really enriched with omega-3 and 6 fatty acids, and also targeted levels of zinc as well. So other topical skin barrier repairs that I use is the Dermacin and the Allerderm. I love both of these products. I love the Dermacin a little bit more because it smells really good. But I do know that some owners are kind of very sensitive to scents, and I would warn them if they prefer a non-scented one, they can choose the Allerderm instead. So again, these are part of the multimodal treatments that I'm talking about. I wouldn't prescribe a box of this for a really itchy dog without any other anti-itch therapies, but I would add it on to potentially the Cytopoint or the Apoquel or whatever else that I'm prescribing, because it is a multimodal therapy management with allergies. All right, so quickly about allergy testing. So at the moment in Hong Kong, I only do blood tests. I don't do intradermal testing, and that's mainly a cultural thing. I did a lot of intradermal testing in Australia, but I find the culture in Australia is slightly different to Hong Kong, where a lot of owners are very fearful of sedations here. You know, the sedation almost equals death. So I found that the blood test is just a lot more easier and pleasant for owners to accept. And so I don't do intradermal testing. There's really no agreed upon research to say one test is more accurate than the other. And I've had really, really good results over the last 2.5 years with just doing blood testing and using that result to formulate my immunotherapy. So I don't think I'm doing like patients injustice or anything if I don't have intradermal testing available. And also remember, atopy is a diagnosis of exclusion of food and flea allergy. So the test alone doesn't, just because you get positive IgE, doesn't necessarily mean the dog is automatically atopic. So you still have to do your due diligence to rule out food and flea allergy first. And immunotherapy or desensitization is really the closest thing we have to a cure for allergies. None of the pharmaceuticals that I talked about really is anything more than a Band-Aid therapy. So this is why I was talking about being really passionate about immunotherapy and allergy testing, is because this really does help dogs actually resolve their symptoms without being dependent on drugs for the rest of their lives. Of course, I'm not saying 100% of these dogs respond, but if we start them early, pick the right cases, and obviously the right clients as well sometimes, then it really, really does make a huge difference. So just remember, food allergy blood tests is still, there's a lot more research that needs to be done. I'm not saying that in the future this might not be a way of diagnosing rather than doing the painful 8-week diet elimination diet trial. But for now, as far as I know, there's no good food allergy blood test available to diagnose a food allergy. So I know a lot of owners always come into my initial consult showing me what their dog is allergic to, and often it says like mushrooms and spring onions, and then I look at them and go, has your dog ever even had a mushroom or a spring onion in its life? And they go, never. And I'm like, well, what makes you think it's allergic to them? So just remember, you know, if you do run them because it's part of the environmental panel, just kind of flip it over and just ignore it casually and just focus on the environmental allergy test part. All right, so immunotherapy, usually I do one of three of these. So sublingual, which is the oral one, and subcutaneous injections, and intralymphatic. Intralymphatic is probably a little bit newer in terms of, I probably only just started doing them about a year ago. And this is a small little amount of their immunotherapy injection injected at the back of their knee into the popliteal. That's the lymph node that I find most easy to access. I've done it in dogs, I've done it in cats, and it's really well tolerated. You'd be surprised. They don't seem to struggle, they don't seem to swell or sting. If anything, there's actually no mast cells inside the lymph node, so if you're hitting it right, you actually don't induce any anaphylactic reactions. But of course, if it goes extra lymph node, then there's always that risk of a type 1 kind of response. But sublingual immunotherapy, I feel, is probably the most popular mode of desensitization in Hong Kong. The reason being, I find a lot of owners here are very fearful of using needles themselves at home. So the subcutaneous injections are at the back of the neck, but the sublingual is daily, and sometimes I'll increase it to twice a day. The glycerin base in the sublingual immunotherapy is sweet. So I would say 99% of my patients enjoy this medication, in inverted commas, and have no issues administering by the owner. And just remembering with immunotherapy, it's a slow process, so it can take 6 to 9 months, which is what I tell the owners. I have seen owners report improvement after 3 months, but that is not the norm. It's definitely more the special case scenario, but it definitely has, in my opinion, at least 60 to 70% improvement in dogs with allergies. So it really is worthwhile pushing for this, because it really does help a lot of allergic dogs. It makes a huge difference rather than just relying on pharmaceuticals forever. All right, so chronic allergies with no management plan. So this is often one of those really sad cases I would see. I think this paw I saw in Australia. This was basically severe pododermatitis, and this dog paw was painful. It would bleed intermittently, and it was basically kind of fusing into one. Like, you can't even see the separate digits anymore. And this is just from chronic allergies. And only treating with a reactive approach, often you will get very frustrated clients, because eventually the drugs are going to run out. You're not going to obviously prescribe 1 year's worth of medicine. And often you will also get multi-drug resistant infections if they're not managed well, and irreversible changes such as this paw. So unfortunately, no amount of medicine that I give it is actually going to make those digits look normal again. The only thing would be a podoplasty or some surgical intervention, but we can at least control the pain, the inflammation, the secondary infection, and hopefully stop the progression of that paw from getting any worse than what it looks like now. So this is a very common list of treatment that I expect my owners to adhere to. So it's not just one drug, go home and see you later. It is 1, 2, 3, 4, 5, 6, everything that I expect you to do. So one is the anti-itch therapy. So this may be the steroids, Apoquel, or Cytopoint. Antimicrobial therapy, especially if dogs are prone to secondary infections, so pyoderma, papule, things like that. And I would request that they use a medicated shampoo to bathe long term. So for example, once a week or twice a week. Ear treatment, if they're prone to ear infections, I would have them have a maintenance ear kind of regimen. And I'm sorry I don't have much more time to talk about otitis, but I feel like otitis deserves an entire hour on its own. But really, ear treatment or ear maintenance is really important as well. Owners often get really frustrated because the dogs relapse in ear infections, and they prescribe the same thing over and over again, and the symptoms the same. And the key is just making sure the ear is cleaned between. You might have steroid ear drops or some kind of medicated ear cleaner, and just ask the owners to do that regularly, because that will significantly reduce the amount of ear infections that dogs will develop within that year, rather than just constantly giving out the Mitex or the Suralan and 6 times in a year. So diet, we talked about things like essential fatty acid enriched diets. Definitely, you can recommend that. I'd much prefer dogs to be on these diets rather than some pet shop brand that I've never heard of and that has potentially very little quality control. If they're got food allergies, of course, then you need to be on a specific diet and avoiding the food allergens. And skin barrier repair, the topical oils that I talked about, I do recommend owners to do this very often as well. Initially, I want them to do it weekly for about a month. And if they're seeing a very good improvement, so reduction in scaling, reduction in the dryness of their skin, then they can do it every 2 to 4 weeks, depending on how the skin looks on their pet. And number 6, finally, is immunotherapy. So again, I know it's a really demanding list, but I find this is the best way to control a lot of allergic dogs. And I find if they are able to do all of this, they don't have as many allergic flares along the way. So the clients get less frustrated. They're not going to be, coming back every month because they're back to where they were before. They have all the tools at home to treat their pet. They have every kind of arsenal at home to manage any minor flares. And that's what I want for my clients. All right. Sorry, I went a little bit over, but Q&A time.